So I'd just like to warmly welcome Marina Kastelan, who's our neuro-oncology nurse practitioner at the Royal North Shore in Sydney. Marina has a wealth of knowledge regarding primary brain tumours and works alongside medical oncologist Helen Wheeler. She is an absolute advocate for patients and carers and is really leading initiatives around Australia to improve care coordination to better improve your journey. So we're really lucky to have Marina here today and travelled from Sydney last night to be here. So please give her a warm welcome.
Hello everyone. Look, I'm really pleased to be here today. It's a massive turnout. We had our brain tumour forum down in Sydney and we probably got, 2 tables worth of people. So it's fantastic that you've all made the journey to come out here today, especially on a Friday. So good to see you. I just want to say a big thank you quickly to Mark, because for us as health professionals, we work in the job day in, day out, and we never manage to get that information out to the general population about how hard it is for certain groups of patients. So to have somebody like Mark come along and actually get the word out to the general population is an amazing thing, and he's just done a brilliant job for that. And you've got to remember, this tumour's a rare tumour, so you're fighting against the breast cancers, the lung cancers, the bowel cancers that have got many more people. So to have somebody that's an ambassador for that is just, it's fantastic for us as health professionals. So I am going to talk about brain swelling today and what we can do about it. So my talk is really specialised. Some of the dialogue in it can be a little bit confusing, and I do find the one thing with brain tumour world, when people come into it all of a sudden, some of the hardest things is the terminology we use. It's a different language. So if you're not understanding things, just sing out. I'm going to try and make sure that I talk in non-medical speak, but you do get caught up in there sometimes. So I thought what I'd go through quickly, and this is probably how some people in this room are presented, because usually presentation for these patients is a quick presentation, and it'll be any of these things that are coming up here. It might be an initial headache. We don't actually often see ongoing headaches usually, so may be an initial headache that brings people in, or they're going to their GP and they're trying to get information or treatment as to why they've got this big headache. Drowsiness, nausea, vomiting, seizures, change in mobility, dragging a leg, dragging an arm, speech changes, personality, memory changes, changes in vision, and sometimes people don't notice this has happened until they ding up the car. And urinary incontinence. The ones I've highlighted in red can really be pushed on by the amount of swelling in your brain caused by the tumour. So the other reason why we also get swelling in the brain is partially from the tumour itself and what the tumour's doing in that closed box, but also the side effects of the treatment we give. So when we then go in and we do treatment like radiation and we cause inflammation in the brain, we then cause more swelling. So it's a bit of a twofold thing, where you get swelling from the initial tumour, you may get some swelling after the surgery you've had, but you'll get it later on after any treatment that we give as well. So we're constantly on this battle to control this swelling in the brain. And you've got to remember, if you had a tumour in your belly, things sort of go out a bit, you might feel a bit nauseous, go off your food, but it doesn't massively impact you. But the problem with swelling in the brain, it's in a closed box, so something's got to give. So this is a scan of a patient that we had recently. That's the other thing. I've got some horrible pictures. If anybody's offended by them, I'm sorry, and I'll flip through them. So this is an image of a brain, and it's just trying to explain why things go awry, whether it's your speech, whether it's mobility, whether it's vision, whether it's headaches, whether it's seizures. So this particular patient's got a lot of swelling there, and you've got a dead centre of your brain. If you've got so much swelling and that swelling is pushing your brain over, the dead central midline of your brain gets pushed over, which is what happened with this lady. So she was in a bit of strife. So the only thing that we've got to control this swelling, and it's usually the first thing, if you come into an emergency department, the first thing they're going to do is load you up with steroids. They've got to get that swelling under control. The only drug that we have to control the swelling is dexamethasone, and I'd say all of you will be very familiar with this drug. It's a corticosteroid. It's a synthetic anti-inflammatory, so it's a man-made drug, anti-inflammatory. I find, even though it's really good for controlling swelling in your brain, if you've got dodgy knees, it's good for your knees as well. It comes in an oral form and an intravenous form, and the tablets come in a 0.5 milligram tablet and a 4 milligram tablet, and then the intravenous comes a little bit higher. Just on a side note, it can come in an eye drop, but we're using that sometimes for different chemotherapy agents we use, so you can get steroid in an eye drop. Dexamethasone's got a really long half-life, and this is my bugbear, and I hope there's no surgeons in the room, but a surgeon will come along and put patients on, 4 milligrams 4 times a day of dexamethasone, when they don't really need to, because it hangs around for a long, long time. So if you had a dose in the morning, it's just as effective as if you had it 4 times a day. But, maybe we just need to educate the neurosurgeons a little bit longer. And the reason I'm talking about this is because this drug causes terrible insomnia, and it's one of the biggest issues for the patients that we see. So this is a couple of slides, and this isn't highlighting all of the side effects with dexamethasone. There are more of them, but these are the major ones. And it's the drug that we love to hate. So we've got to use it, we've got no choice, but it causes a lot of problems. And this is what we're constantly trying to battle. So it can make you retain fluid. So you retain, when you're taking dexamethasone, you retain salt, you retain fluid, you get puffy hands and feet, and your blood pressure can go up. It can mask some signs of infection and make you more prone to certain infections. It can give you big behavioural and personality changes. People can become teary, they become emotional. I've seen a couple of people that have had a really terrible psychosis on dexamethasone. It can be a rotten drug. It causes terrible insomnia. I say to people, if you go from Sydney to the UK on a flight, you don't sleep, you turn around, you come back, and then you try to go to work. That's what the insomnia is like on dexamethasone. You can't function on no sleep, and you're going to go mad. Doesn't matter who you are. So it's a real challenge with this drug. The other thing that it gives is those mood swings, as I said, the teariness, the elevation. I've had patients, I've got a gentleman recently, and he's managed to clean out the attic, the garage, everything's on eBay, and it's all happened in about a week. The house is about to be painted. So look, it can be a great drug, but some people love it and some hate it. The other thing that it can cause is impaired wound healing, and that can be, we see every now and then where, you're 40 years of age, 50 years of age, and all of a sudden you've got acne on your face, back and chest. So it can cause those acneiform eruptions. It can cause stretch marks. So as you put on excessive amounts of weight and your elastin in your skin isn't keeping up with it, you can end up with stretch marks, and I'll show you that in a minute. Then thinning of the skin and skin fragility. This Cushing syndrome, where people are very typical, where they get that big moon face, increase in blood sugar levels. It's a bugger of a drug if you're a diabetic. And the other biggest issue that we have with it is it causes this muscle weakness. So what happens is you put on fat on your belly, and the big muscles in your arms and legs that you need to walk and keep you upright get chewed away. So you put on weight and you lose all the muscle tone. So, exercise in this group of patients is super, super important. You've got to keep moving if you're on steroids. And I know that can sometimes be a challenge, but it's the best advice I can give people is get out there and move around. So this is a lady this is just the thinning of the skin and the bruising, so it can make people look terrible. This is stretch marks. A young fellow, he was only about 18, 19, put massive amount of weight on in a very short amount of time, was on steroids for a long time and ended up with all these stretch marks, which for him as a, adolescent was a major thing. And this picture here, this is what happened afterwards because he ended up with an infection because these stretch marks broke down and he ended up with an infection in these stretch marks. And this is all from staying on decks for too long. So it's a drug we need to use. We've got no choice, but we need to also be aware of the negative effects of it. So what can we do? And I have to say here that I'm not a rep for Avastin, but this is just trying to give different alternatives. So before we go on and talk about the alternatives, we've got to understand why we get this swelling in the brain. So this is called angiogenesis. And so any glioblastomas or high-grade brain tumours are highly vascular, big blood supply feeding that tumour, giving it the energy that it needs, the oxygen that it needs to grow. And the angiogenesis is the process where the tumour's encouraging new blood vessels. So grow more blood vessels, go crazy, all right? And the main promoter of the angiogenesis is this factor called VEGF, or vascular endothelial growth factor. And the tumour's madly putting this out, saying to the tumour, grow these vessels we need to get energy. Now, I just want to say at this point, this isn't the only thing that's going on, and it's all very simple to say if we get rid of this, we'll stop the energy source to the tumour and your tumour settles down. There's lots of other things going on that tumour's putting out to get the tumour to grow. And that's where all the research is going. Which bits of the puzzle can we stop amongst the 50 different pathways that are occurring for that tumour to grow? Which ones can we block that are going to give us our best bang for our buck? Because these tumours are smart. So the VEGF is produced by the tumour cells in response to poor oxygen. So if the tumour's not getting enough energy and oxygen, it's putting out this VEGF and saying, grow to get us more energy. So they're clever buggers. So the tumour vessels in gliomas are both structurally and functionally abnormal. They're leaky vessels. So you've got this mad mesh of blood supply that's more than other normal cells, and then these vessels are leaky. And that's why you get the swelling, or part of the reason why you get the swelling in the brain. So it's a bit of a challenge for us. So glioblastomas are rich in blood vessels, so they're highly vascular, and in that protein known as VEGF, which promotes the new blood vessel formation. This is just a graphic of that. So you can see on your left where you've got this tumour that's popped up, it's secreting this vascular endothelial growth factor, telling the tumour to grow, then forms more blood vessels, and the tumour has more blood vessels and continues to grow. So what Avastin does is Avastin prunes the vessels. That's the aim of it. So it'll prune the vessels and normalise the blood vessels. So those leaky holes that are in the vessels, it'll plug those up. So it's kind of got two factors where it chops off the blood supply, but it also plugs up the holes to stop the swelling, all right? So this abnormal angiogenesis in the GBM causes significant symptomatic problems for the patient, which is unique. So as I said, if you've got a breast cancer, a bowel, something else, you don't have these things going on. You can not potentially going to have seizures. You can continue to drive your car, all these sorts of things. So it's a unique thing for the patients that we see. So the increased permeability causes interstitial pressure within the brain and the vessels, causing this brain swelling, and potentially can cause a risk of hemorrhage. I actually don't see hemorrhage a lot, I've got to say, but some people, that's what they present with. You find that they've had a hemorrhage out of the blue in the brain, a bleed in the brain, and they'll present to emergency, and lo and behold, you kind of find this tumour underneath it after a while. So this is where we talk about bevacizumab, which is a generic name, or Avastin, which everybody knows about. So Avastin is a drug. The rumours started circulating. It's been around for a long time now, so about 2005, and they were saying initially that it was going to be the wonder drug, had about a 70% response rate in glioblastoma. So it looked like the new big thing to us, and we were like, this sounds great, it's a magic thing. So they started doing trials on this drug and put it in different groups of patients. So ASCO is the American Society of Clinical Oncology, which is one of our big oncology meetings. So they started publishing papers in May, or presenting them in May 2006 about this drug. So it's been around for a while, and we've had a little bit of experience with it now. Initial data was published in some of the oncology journals back in 2007. And we treated the first patient in Australia in 2005. I've got to say, you know, when I think back to when we first started using this drug, because some of it was anecdotal, you know, it was being used in the States, you know, we'd go to these conferences, you'd get chatting with people, and you weren't really 100% sure of what you were giving. And back then we were sort of thinking we'd cause major bleeding in people, blood clots, all of these big issues. So when we first started giving it, we'd admit patients, they'd stay in hospital a couple of days, and, you know, touch wood, I didn't actually see too many problems at all with it. You know, I'm not saying that it's an indolent drug. It's got its issues, but it wasn't as bad as some of the data had put out. So what is Avastin? It's a monoclonal antibody. It's not a chemotherapy agent. It's not a cytotoxic. It's given intravenously. They keep talking for the last few years about it coming out in a pill, which would be lovely. But because it's intravenous, we have to bring people in. And in my mind, with the treatment that you're going through, the least amount of time I can get you in hospital and the more time you can spend at home or on holidays is what this is all about. So, you know, the issue for me is, you know, bringing people and dragging them into hospital, you know. And on top of that, you all know if, you know, you're coming into hospital, somebody's bringing you in there. So it's not just you we're impacting the person that's driving you in as well. So it's given intravenously, usually every 2 to 3 weeks. Now, what Avastin does is it binds and neutralises that VEGF. And that's how it does that pruning and blocking up of the vessels. And some cancer cells, i.e. glioblastomas, make a lot of that VEGF to tell themselves to grow. So by neutralising the activity of the VEGF, we can reduce the vascularisation of the tumour and potentially inhibit growth. The problem with Avastin is it initially will inhibit that growth, because if you're chopping off the blood supply and you're chopping off the oxygen flow and energy to that tumour, you can get initial reduction in the tumour size, but after a while the tumour says, blow you've blocked that pathway, I'm going to find this highway to work out how to grow. And that's the challenge for us. So it's not the great drug that, you know, we'd hoped it would be. The other thing with Avastin that we got caught up when we first started using it, it actually, which is great for the patient, it works really fast. So I usually find within 24, 48 hours of giving the drug, if people are going to get benefit from the drug, it usually happens pretty quickly. So most patients get a benefit within about 48 hours of having the drug. Their symptoms are relieved, they're able to start coming off the steroid. And some patients I find things improve about a week later, and it depends on the symptoms the person was getting as a result of the brain swelling in the first place. But what it does do is it very much changes the way your MRI looks. So all of a sudden, your MRI will look fantastic, and we know that that's not true of true image of what's actually happening with the person. So I've put some. So you'll see here there's a fellow here that's got a lot of brain swelling with a frontal lobe tumour on your left. your left. And that was before Avastin, and this is after Avastin. So you see that it makes the MRI look fantastic. So for us as clinicians, it's a bit hard to work out what's actually going on. And back when we first started using Avastin and we'd do these images, we thought we were curing people. And we know now that that's not the case. It's just getting rid of all of that swelling and it's making the MRI look really good. And some clinicians stop doing MRIs because they become irrelevant after a while. If you've got a patient that walks in, looks fantastic, is on lower dose of dexamethasone, what difference does the MRI make after a while, And trying to get people to pull away from the MRIs and stop doing them, that's a bit hard, So this also has side effects. Everything has side effects. And the main ones from this, I've just put a few of these down as well. It's not all of them. The main ones is gastrointestinal perforations and fistulas. You can't give it within 28 days, so around that 4 to 6 weeks of doing surgery, because it does inhibit wound healing. So from my experience, and we've been using this drug for a good 12 years now, I've seen one GI perforation. It was actually in a patient where she was constipated and they gave her an enema without sort of knowing what was going on with the Avastin, and she perforated. But I've never ever seen a perforation other than that. In regard to the wound healing, we're careful about that. I mean, if we're going to give Avastin, we're obviously meeting up with our surgeons and getting opinions from our surgeons and working out whether they can do any further surgery and what the benefits of that would be before we would give this drug. So you're working really heavily in with your medical oncology, your neurosurgeon, your radiation oncologist. It's a big team. Not one of us can fix what's going on. You need to have all those people in, your backpack doing things to help you out. And in regard to the wound healing, the only time I've actually ever seen a wound breakdown was a lady who was on one of the initial trials of this drug, and the wound broke down about 18 months later, and I've never seen it again since. But we are very cautious of this. You only have to see it once and, you're wary of it. Hemorrhage, and this was a big thing, but if you've got a brain lesion, that's one of the risk factors of having a lesion in your brain, is potentially that you could bleed into that tumour. It's a highly vascular tumour and it can just suddenly bleed. I don't see that a huge amount as well, I've got to say, which is good. It can give you clots in your arteries and veins. We tend to, before we give Avastin, is check people out to make sure they haven't got clots in their lungs and legs before we give the Avastin. You got to remember people with gastro, like head and neck cancers, gastro cancers and brain, of all the cancers, are the highest rate to clot. So we're in a group that, because of the tissue factor that the tumour's putting out, you're more likely to clot anyway, So we tend to see clots a lot, and they're not really a huge big deal. It just means you're giving yourself Clexane each day, and I say that. If I had to give myself Clexane, I'd probably have a heart attack, but there we go. But the main thing that I do see with this drug and that you have to watch is the high blood pressure, and I tend to see it in people that have already got a bit of blood pressure problem. Your blood pressure needs to be monitored every time you have the Avastin. If the blood pressure starts to creep up, you need to see your GP or liaise with your oncologist to get onto a blood pressure tablet. If you leave it, it'll just keep creeping up and you'll end up with a big blood pressure problem. The other thing that it can do is this damage to the kidneys and make you put urine out through your kidneys when you wee. So that's another thing. Each time you have Avastin, we've got to make sure that we actually do a protein check in the urine. I've never actually seen an infusion reaction. Have you girls ever seen? Yeah. So there was less than 0.2% of patients had an infusion reaction. So I suppose anything that you can have a a reaction. So there's been a lot of trials used with Avastin. One of the big ones, we were involved in one called Avaglio some years ago, and they trialled giving Avastin up front. So you were newly diagnosed, they waited that 28 days after surgery, and then you had radiation and the temozolomide, and we would give half the people Avastin and the other half got a bag of water. So there's been a lot of trials used for this drug. So these are the most reported or most common reported side effects in the trials. So nosebleeds, and I do see that every now and then. I've had one or two patients that have had to get a cauterised vessel in their nose because of the ongoing nosebleed. I've never really seen a headache. High blood pressure can be common. You've just got to monitor it. As I said, you need to check it at every infusion and treat it with a blood pressure tablet. The proteinuria is a true thing. You've got to watch out for it. And then they listed all these other things down there. The biggest issue that I find for patients is the cost of the drug. So, and that can be inhibiting for some people. And some doctors will, say that Avastin's just a really expensive dexamethasone because it's kind of doing the similar sort of thing. I like the drug. If it would just be better if patients didn't have to pay for it. I think if it's used in the right setting, it can be a good quality of life drug for people. So there's Roche, who make the drug, have got a scheme where you pay for 6 and then you get the rest at no cost. So I've had some patients on this drug for 12 months. So, the problem is those first 6 doses can be anywhere between $3,000 to $4,000 per dose. What we tend to do is give a dose, and you usually find out whether it's working pretty quickly. So with 1 or 2 doses, you'll know whether the drug's working or not. And people will say, how do you know it's working? And most of the time, if you can get off the steroids and reduce the steroids without going backwards, the drug's having a benefit. So rather than pay the full 6 up front, you pay as you go sort of thing, a little bit of a lay-by, and it's not so hard on the hip pocket then. But that is one of the biggest things, and that's inhibiting for people. That's a lot of money. If somebody said to me, we've got this drug, we think it'll be really good for you, but hello, it's $3,500. I think I'm not sure where I'd get $3,500 from, to be quite honest. So that's the one big thing with it. Now, with our government and Medicare and the pharmaceutical benefits scheme that our tax pays for, so obviously they are going to put things onto the PBS according to different studies and whether we've managed to get a better survival for people. So they have a look at the trials that we do, and if you've got a drug that's offering, better survival for patients, well, they're going to say, okay, that's a good thing, it's safe, it's a good thing to do, we'll put it on the PBS and we'll cover for it. So here in Australia, the only things that are covered on the PBS with Avastin is ovarian cancer. They keep changing it a little bit because breast used to be on there and that came off. But ovarian, carcinoma of the cervix and metastatic colorectal is the only patients that are going to get Avastin on the PBS. So it's not covered on the PBS. But the TGA, the governing body for the safety aspect of it, have said, yes, it's fine for us to use it. So fine for us to use, but we're not going to pay for it at the moment. And this is what the TGA have said that they've said that it's fine to use. So it's a single agent for the treatment of patients with grade 4 gliomas after relapse. So they're not encouraging us to use it in early setting when you're newly diagnosed, but when you've relapsed and you're having problems with swelling, it's a good drug to use then. And this information came out that part of that Avaglio study because that was a failed study. It basically showed us that Avaglio study where we were giving Avastin up front, that patients were no better whether they got the bag of water or the Avastin. So the government aren't going to say, let's pay, all the money to get that. But they found that it's good if you've got relapsed disease and you're having troubles with brain swelling, that we can use it in that setting. So what's happened recently, the PBAC, who's the Pharmaceutical Benefits Advisory Committee, and the brain tumour community, I'm not good at keeping time, how are we going, have all come together, and this is everybody who's involved with brain tumour stuff. It would have been BTAA, Mark Hughes Foundation and everybody else that's involved with it, have put in submissions to the PBAC to basically say this is a really good drug for patients and you need to put it onto the PBS. And you can read the submissions. I had quite a few patients and relatives that actually went to some of the meetings and put forward their own information about it. So it was a really good thing. And I think, you know, for us to have a voice, you know, and as I was saying earlier with Mark and what he's done, it's about getting the word out there. And through that, we've managed to mobilise anybody who's interested in primary brain tumours and some patients and carers to come and say, you know, this is what we want. We need to fight for what we want. And if we can get this drug on the PBS, that would be a massive benefit for patients. And that's about all I have to say on that. Has anybody got any questions or things before I do it after? All right. Okay, that's the end of my... It's a conundrum for us.